I'm a neurosurgeon and a neuroscience researcher at UCSF, and I think for the purposes of this kind of organization as a group of talks, I was really asked to spend the next 10, 15 minutes focusing on to the non-surgeons in the audience and what the non-surgeon really should know that we think about in surgery and considering our surgical goals for patients. So again, non-surgeons, we think about brain tumor workup, and this is really going to focus on gliomas more than brain metastasis, given the short period of time. What are our goals of surgery? And then, what harm can we do as surgeons? What is the impact of neurologic impairments on outcome? And so, again, just briefly going through the workup, because many of the audience already know this, a basic brain tumor workup involves non-invasive imaging modalities such as CT scans, MRIs with and without contrast, DWI, perfusion imaging, MR spectroscopy, some PET, depending upon where you are, and then functional correlates in imaging such as DTI and MEG, magnetic encephalography. These are all tools that we use to understand where the lesion is and what it may be. But it's important as we think about workup, taking a step back to really understand and wrap our minds around that fact that everything contrast enhancing in a tumor is really not all a glioma. So again, the workhorse of non-invasive imaging is a MRI, and we know that all these different contrast enhancing lesions don't all represent tumors. Everything that's ring enhancing doesn't represent a glioma. We have to think about brain abscesses, TB, demyelinating disease in particular. Show this example of a ring enhancing contrast enhancing right frontal mass with surrounding edema or flare signal. And you can see, looking at the diffusion weighted central DWI and ADC is dark, this lesion restricts diffusion, is actually a brain abscess. So, we use all these sequences to tailor our differential diagnosis and our surgical plan as we move forward with patients. Earlier on, you had the discussion about imaging tools and novel, innovative imaging strategies that we use to help guide resection. But I think, again, as we really try to pick apart our treatment and what we want our non-surgeons to think about in treatment, is how do we counsel patients? And we know that really how we counsel patients depends on the interactive effects of a number of clinical and molecular characteristics or presumed characteristics based on tumor volume, location, the functional status of the patient, medical comorbidities, social support, what we play a part in understanding or thinking about what our surgical goals are. So again, as we first focus on low-grade gliomas and why we operate and when, since molecular subclassification really began in the years leading up to 2016, we have to take our lumpers hat away, meaning taking all gliomas and just grouping them into one category, and really understand and think about the fact that we split now gliomas into multiple subgroups. In the low-grade glioma, diffuse glioma category, we really are thinking about oligodendrogliomas, IDH wild type, and IDH mutant astrocytomas. And it's really had been poorly understood what the impact of extensive resection was on each of these patients, meaning why do we put each individual group at risk if we don't understand what the extensive resection benefits are. And you can see here, actually, if you this is a wonderful paper by Tim Smith at the MGH group, which published just a couple of months ago, which really showed that, again, if you take all of our extensive resection data, for all of our diffuse low-grade gliomas and these three families, and look at survival with percent survival, overall survival with extended resection, you can see here that extended resection seems to matter and survival seems to matter, specifically looking at this graph, whether you're talking about oligodendrogliomas, IDH wild type, IDH mutant astrocytomas. But let's kind of break these down individually. If you think about our oligodendroglioma patients and you look in the upper right hand part of this figure here, you can look that and you can see that the volume of residual, meaning less than 0.1 centimeter cubed, extended resection volume of residual after extended resection is a significant correlator with overall survival compared with greater volume of residual. So they stratified based on these categories of volume of residual for even our well-performing oligodendroglioma patients, and they could see that extended resection matters even for our oligos, which is really helpful to understand whether we should be offering surgery even for patients with more thought benign indolent disease. The same held true in this analysis for IDH mutant or IDH wild type astrocytomas. You can see here again that less volume of residual, better survival, greater volume of residual with greater than 15 centimeters cubed, less overall survival in the Kaplan-Meier survival curve. And they used the all low-grade glioma metric here and looked at all of their oligos astrocytomas and whether they are IDH wild type or IDH mutant, and showed that even across molecular subgroups, they found a significance, meaning greater survival with less volume of residual using their linear regression model. And there are several predictors of outcome, including postoperative residual volume being one of them. And so that was a really helpful study to look at. But as we're thinking through this innovative brain tumors session today, we understand that most of our gliomas are going to be for patients with high-grade disease. So we have to circle back and think about our high-grade gliomas and what are our surgical goals and why. And if we stop for a minute and think about the interactive effects of volumetric extended resection on outcome for molecularly defined subgrouped tumors with oncologic factors, we can develop a roadmap here for the role of cytoreduction in surgery. This is a study we published earlier last year, which again took 20 years worth of data, 850 patients with newly diagnosed glioblastoma, both IDH wild type and IDH mutant, splitting patients up into the Stoop era and before, focusing for the most of this data will focus on the post-Stoop era. And you can see here a nice log hazard ratio of glioma mortality based on extended resection as a continuous variable. You can see greater extended resection, particularly over the 80% mark, means lower log hazard ratio mortality. And again, I'll focus on this slide for a minute. And you can see here that if you use a multivariate statistical model, we used a recursive partitioning analysis that really forms decision trees, including roughly 150 clinical and molecular variables to determine outcome. You can use these multivariate statistical model to help give a roadmap to what our goals are with respect to treatment. So again, take all patients with IDH wild type glioblastoma, and you can see outcome was determined predominantly based on four variables, four Kaplan-Meier curves, and four splits in our decision trees. And you can see here that patients who did not receive temozolomide fared the worst. Patients who fared the best, this blue group, had IDH wild type glioblastoma with a lower age, a younger age, and a greater extended resection of the non-contrast enhancing tumor, and they co-clustered with patients who were IDH, who also received temozolomide and were IDH mutant. That's this best performing category here. And you see everyone in the middle includes patients with IDH wild type, older age patients. Those are your red, and your green are, again, those IDH wild type, under the age of 65, with a slightly greater volume of residual. The important part in this slide really is section B, the Kaplan-Meier survival curve here, which really changed the way you started to think about our extended resection goals. And you can see here in this slide, we break apart our light blue into individuals who are IDH wild type and IDH mutant, meaning co-clustered of these light blue. Your aqua are your IDH mutant patients who receive temozolomide. Your dark blue are your IDH wild type who have greater extended resection of the non-enhancing tumor volume. You can see here, again, in this data, that you can make even the most molecularly risky IDH wild type patients perform similar to an IDH mutant patient for roughly 2.5, almost 3 years, with greater extended resection of the contrast enhancing disease if they're under the age of 65. So that really made us rethink our treatment strategy and our surgery goals for patients with newly diagnosed IDH wild type IDH wild type and IDH mutant glioblastoma. So we know temozolomide treated patients that are IDH wild type and over the age of 65 clearly benefit from extended resection of the enhancing tumor. We know these IDH wild type patients that are temozolomide treated under the age of 65 perform similar to our IDH mutant temozolomide treated patients when we maximize extended resection of the non-enhancing tumor, of as much non-enhancing tumor as possible, and those faring worse are those who did not receive temozolomide and are over the age of 65. But there was an important part in this paper that I really wanted, again, to think about for a few minutes, and that is, what are the consequences of neurologic impairments on outcome? And again, for the paper I just described, we didn't include that in the analysis. So under review right now, I'll share this data that really has opened my eyes and helped me understand a little deeper into that data. We understand the impact of new neurologic impairments on outcomes. So if you look at our univariate statistical model, and could see that, again, new post-op neurologic impairments, particularly cognitive and hemiparesis, cognitive and weakness, impact survival. And then if we take these patients with who only received temozolomide and are IDH wild type treated, who are IDH wild type and received temozolomide, nobody who did not receive temozolomide is included in this group, and then rerun the RPA that I just showed you, the recursive partitioning multivariate statistical model that I showed you before, it actually changes the model. And you can see here that our best performing group now really is determined based on, group one is really determined based on extended resection and presence or absence of any new neurologic impairments. So again, if you have 100% extended resection and no neurologic impairments in this model, there's really a remarkable 28-month median survival, which is pretty striking in comparison to the rest. So again, our worst performing group now, when you add in neurologic impairments, are those patients with less than gross total resection with one or more neurologic impairments. And a greater amount of non-enhancing disease remaining. So again, this helps us understand that, again, it's not extended resection at all costs. Neurologic impairments are a critical, important part of patient outcome. And it's really important, again, as we think about our surgical goals, that we factor into decision-making and the risk that's on outcome, and try to offer the safest operation possible.
Thank you so much, Shawn. And we have a few minutes. We've caught up in our schedule, and I'd love to have the panelists all turn on their cameras, because I think this is a great topic for conversation, and that really is, how do we make our decisions and how do we counsel patients when it comes to operable versus inoperable brain tumors, factoring in the impact of a new neurologic deficit post-surgery. And I know that that pendulum has swung widely in many directions. You've witnessed that firsthand in terms of extent of resection at any cost. And I think we're swinging back. But how are people counseling, and what would people tell our attendees today is current standard or best practice as far as counseling patients when it comes to high-grade glioma and whether or not a lesion is truly operable with a goal of near total or gross total resection? And Shawn, we'll start with you.
Yeah, I'll be honest. When the JAMA paper came out, I actually lost sleep over that a little bit, because the implications can go beyond the stated data, meaning the intentions of that data was never to remove as much contrast enhancing disease as possible. It was to do a functional operation. Here at UCSF, we see a lot of patients with tumors in eloquent areas. So you end up doing a functionally guided operation much of the time, which ends up, the effect is that you end up removing non-enhancing disease. What I fear came out in that paper was remove as much non-enhancing disease as you can, which is really the reason behind myself and some others circling back to say, okay, we have all these wonderful imaging tools. I know Kostas went over that with the group. It's just, we're getting better and better at understanding what's tumor and what's not in the intraoperative setting, with some limitations, but better and better at it. but it's not extended resection at all costs. So much of the discussion for me with patients is guided based on their preferences, meaning like, what is a good functional outcome for you? What does survivorship look like for you? And it's different for every patient. An accountant that I'm, operating on next week is a little different from, a journalist, right, with respect to what their goals of the operation are. So I think these kind of patient-guided discussions are really critical as we think about our surgical operative goals.